the housekeeping items, and it is my pleasure to introduce our speaker today, Professor Jérôme Honnorat. He is a neuro-oncologist with a particular interest in perineoplastic neurological syndromes, PNS, and autoimmune encephalitis, AE, with a particular interest on immune cerebellar ataxia. His main research is to describe the clinical specificities of AE and PNS to identify new biomarkers of these diseases, leading to patients and close relationships with industrial companies and to develop these diagnostic tests. Professor Honnorat has conducted several research projects in the field of PNS and A&E, from fundamental studies on the role of antigens in brain development and in synapse functioning, to translational studies to validate autoantibodies as diagnostic biomarkers and to understand the immune breakdown leading to these immune diseases, as well as clinical studies to describe the specificities of patients at the clinical and biological levels, as well as genetic levels. He described cerebellar ataxia with anti-GAD65 autoantibodies, perineoplastic cerebellar ataxia with anti-CV2 CRMP5 autoantibodies, and participated in many different works to describe and to understand the mechanisms of immune cerebellar ataxia. After 30 years of work in this field, he has led and participated in many national and international programs and has published several international guidelines on this subject. He is really the expert in this field, and it's a privilege for us to have him today to speak with us. So with that, I will turn the floor over to Professor Honnorat. Please take it away. The floor is yours. Oh, Professor Honnorat, are you able to hear us? Sorry, folks, it seems like we're having some technical difficulties here. If you just give us 1 second. It seems that his internet connection has been lost. Sorry about this, folks. If you just give us 1 second, we're going to fix this and get Professor Honnorat back on the call. Hi, Professor Honnorat, can you hear us?
Yeah, I lost you, but I'm back.
Oh, fantastic. So if you want to share your screen, we'll jump right into things.
Yeah, very sorry. We have some connection problems.
No worries at all. Technology is funny that way.
Is it okay?
Yep, we can see your presentation. All right, the floor is yours.
Okay, thank you very much. And thank you to give me the opportunity to present my work on immune-mediated cerebellar ataxia. As told Celeste, I'm a neuro-oncologist. It could be a little bit surprising that a neuro-oncologist is interested by immune cerebellar ataxia, but you will see that I'm interested by all neurological events in patients with cancer, and paraneoplastic neurological syndromes are very important for us. And I started my work interested by patients developing cerebellar ataxia in a context of tumors such as lung or ovary or breast cancer. So I'm interested by this disease, and neurologists are very interested by immune-mediated cerebellar ataxia for many years, because we described autoantibodies at the beginning, HU and YO autoantibodies that were used as diagnostic biomarkers of paraneoplastic neurological syndromes. And we will describe exactly what is it. And these autoantibodies are highly specific, around 100%. And if you have in your CSF or in your serum such autoantibodies, we know that you may have a tumor. And in most of the patients, the tumor is very small and difficult to diagnose. And so you can see that between 1965 and 2000, we described different kinds of autoantibodies, all related with a particular neurological syndromes and a particular tumors. And after that, you can see the increasing number of autoantibodies that have been described and less associated with cancer. And so we identified a lot of autoimmune disease, and most of them with cerebellar ataxia. And so it's a field that is growing very quickly with different kinds of patients, even if for each autoantibodies, the disease are rare. So what's exactly a paraneoplastic neurological syndrome? You may have a clear observation with these patients. It was a 63-year-old woman without particular medical history who developed in few days a subacute cerebellar ataxia. And in less than 1 month, you can see what's happened exactly with the cerebellar ataxia, shaking, impossibility to walk or even to stay. You can see here, it's only cerebellar ataxia. And we identified anti-YO autoantibodies in their CSF and sera. And you can see here an illustration of the staining on the rat slides. This antigen is expressed only in Purkinje cells in the cerebellum. And when you have these circulating autoantibodies, we know that these patients have a cancer, but we look at with radiological examination, we look at in the breast and we find nothing. We look at in the pelvis, there is nothing, but we performed a surgical exploration and we identified an ovarian carcinoma, in bilateral ovarian carcinoma that was not possible to see by radiological examination because the tumor was too small. And it's typical of a paraneoplastic neurological syndrome. There is a cancer, but it's always very small. And the patients develop immune reaction against the tumor cells. And this immune reaction is able to destroy the neurons in the brain. And in this patient, it was the Purkinje cells. You can see on these photographies a normal cerebellum of a patient who has died from heart infarct. And you can see the Purkinje cells that are the big neurons between granular cells and molecular layer. And in the patient's cerebellum, there is a disappearance of the Purkinje cell because they was destroyed by the immune reaction. It's a very interesting syndrome because we can suspect, because the tumor are very small, that the immune reaction is efficient to control the tumor proliferation, but in the same time, as they think that the immune cells think that the same antigens is present in the brain, they destroy the neurons and provoke the cerebellar ataxia. So in the 20th century, we thought that it was clear that the autoantibodies could play a direct role to destroy the Purkinje cells because the antigen was in the Purkinje cells. But many different groups around the world try to develop animal models of this disease with stimulation with tumor or to inject directly in the brain of mice of the autoantibodies. And nobody was able to reproduce paraneoplastic syndromes in mice or other animals. And at the end of the 2000, we thought that the autoantibodies was very nice biomarker of the disease, but that the mechanisms was a role of the T cells to destroy the neurons. And so we worked a lot to try to develop animal models, but at this time, it's impossible to know exactly the fine mechanisms of the immune reaction, but autoantibodies can be used as very nice biomarkers to be sure that a cerebral ataxia is linked with the presence of a cancer. But this disease is very, very rare. Between 2000 and 2008, we described in Europe only less than 1,000 cases. No, it's not a lot. And for the main frequent autoantibodies, you can see that in France, at these times, we diagnosed around 40 HU patients per year, not all with cerebral ataxia, and between 12 to 20 patients with YO antibodies per year. So it's not a lot. It's clearly a rare disease, but very important to diagnose, to be able to diagnose very quickly this patient, to remove the tumor and stop the immune reaction before a total neuronal death. We can observe different kinds of paraneoplastic neurological syndromes. You can see that cerebellar degeneration is frequent, is 1/4 of the total of the patient in this series. But in fact, limbic encephalitis is also frequent, but less than 10% in this series. Just before, you will see that we describe new autoantibodies in the last years. And limbic encephalitis, it's encephalitis of the hippocampus, is present in fact, it's the most frequent paraneoplastic syndromes. And the other most frequent symptoms is sensory neuronopathy in 1/4 of the patient. But as you can see, we can observe many, many different neurological symptoms that are related with the presence of a tumor. Yeah, there is a discussion because it was rare, but during these studies between 2000 and 2008, only 3 biomarkers of autoantibodies were well known, and there were no biomarkers for limbic encephalitis. So the cerebral ataxia symptoms and the outcome vary according to the associated autoantibodies. It's always rare, but if you have a particular autoantibody, you will have a particular clinical presentation and a particular evolution. You can see this patient of 57 years old. He developed this cerebral ataxia in less than 1 month. And you can see that is less severe than the woman that I present with anti-YO antibodies, because it's 2 years after the onset of the symptoms and is always able to walk. But he developed cerebral ataxia, and he had anti-CV2CRM5 autoantibodies, and in fact, a small cell lung cancer in the mediastinum, and we were able to identify clearly the cancer only 2 years after the onset of the symptoms. And so this observation demonstrates that the evolution of the cancer is very slow and very different than patients without paraneoplastic neurological syndromes. Another case is younger patients.
Très rapidement.
You can
Combien de temps se sont installés?
dysarthria.
15 jours. Et après.
So, in fact, she had signs of Hodgkin lymphoma with increase of the size of lymph nodes, and we diagnosed Hodgkin lymphoma, and at the same time, he developed dysarthria, get ataxia, and he was bedridden at the onset of the chemotherapy because of the cerebellar ataxia. But as you can see, 1 year after the diagnosis, he was able to walk. So he improved after the diagnosis. And so we can suspect that the symptoms were not due to neuronal death, but neuronal blockage. And we will discuss about that later. So DINAR was the associated autoantibodies, and these autoantibodies is always associated to Hodgkin lymphoma in patients that are able to improve if we can do the diagnosis very quickly to treat the patients and to improve them with immunotherapy. Another one is a patient with anti-RI antibodies, and you can see that she's able to walk. She has a weak cerebellar ataxia, but it looks like more multisystemic atrophia or Parkinson's disease because it's not acute, it's subacute in few months, and you can see the abnormal movement of the eyes. She is not able to follow the finger of the medical doctor who examined her, and it looked like a particular symptoms called Stiller-Richardson disease, that it's a neurodegenerative disease and not a cancer-associated neurological syndromes. But she had anti-RI autoantibodies, and we identified a breast cancer in these patients. The CSF was inflammatory, and so we are sure that it was a paraneoplastic syndrome and not a neurodegenerative one. And we recently reviewed all the cases of patients with anti-RI autoantibodies and demonstrated that you may have an association of different symptoms: cerebellar, tremor, oculomotor, confusion, sometimes Parkinsonism, that, look like neurodegenerative disease in most of the women in the first month of after the onset of the disease. And you can see that in around 20% of the patients, you need more than 6 months before to have the established symptoms that are mainly cerebellar ataxia with other symptoms. And you can see the association of cerebellar ataxia with dystonia, oculomotor symptoms, ophthalmoclonus, Parkinsonisms, or spasticity. And so it's very, very complex before to have the established symptoms and the association of different symptoms. And so in most of the cases, the physicians are not able to do the diagnosis without the identification of the autoantibodies and suggest that it's neurodegenerative and not paraneoplastic. Recently, a new one, autoantibodies have been described as Kelch-like protein 11 antibodies. It's mainly in men with seminoma, testicular seminoma cancer, and associated with encephalitis. We recently reported 11 patients with such autoantibodies. It's an association of prominent cerebellar involvement in 11 patients, severe weight loss, and hearing loss or tinnitus. It's a case of this patient, and you can see the cerebellar ataxia of this patient that appear in few weeks. So it's another point that it's interesting in this patient is that he had a possible testicular cancer, but we did the diagnosis on a lymph node metastasis because we observed in the testis a burnout tumor, suggesting that the immune system is particularly efficient in the primary tumor and able to destroy the tumor cells, but not the lymph node metastasis. And during the lymph node metastasis process, there is an activation of the immune system, and the immune system will play a role to block the function and to destroy some neurons in the brain. So it's a very interesting subgroup of patients because we can better understand what's happened in the primary tumor to activate the immune cells. These immune cells are able to destroy the cancer, but also to provoke the neurological symptoms. And so we have some question of the how the immune tolerance is broken in paraneoplastic neurological syndromes, and we are working to understand this point. But in some cases, and I published in 2001 a series of patients, what was very particular, we have a lot of arguments to think that these patients are immune-mediated, but without associated cancer. And so it was the case of this woman. You can see the cerebellar ataxia. She was 74 years old, but she developed progressively the cerebellar ataxia for 3 years with late onset diabetes mellitus. What does it mean? It's diabetes mellitus. She needs insulin to be treated, but she was very old, and so it's not usual to have insulin-dependent diabetes mellitus without obesity. And so it was very particular, and a story of thyroiditis. So at least 2 other autoimmune disease in these patients that was very particular, and no associated cancer. Another particular symptom is this one. When we look at her eyes, you can see an myoclonus that is on the right side, on this side. You can see. But after a few seconds, it changed the size and now is on the left, or her right, and before her left. You can see the change. And we know that this is under the control of the flocculus. It's a part of the cerebellum, and the flocculus used GABAergic neurons. And so we treated her with baclofen, that is an antagonist of the GABAergic neuron. They play a role to increase the level of GABA. And so you can see that there is no more myoclonus. And so we were able to, with an increasing of the level of GABA, to stop the myoclonus, suggesting that GABA is involved in the pathology. And so it was very important because glutamate decarboxylase, also called GAD, is the enzyme that transforms glutamate to GABA. And so probably the antibodies were able to block the production of GABA, and it was a possible treatment of the cerebral ataxia, and we improved some patients using baclofen at high level. Sorry, I have a problem with my presentation. Okay. And so we published a series of patients, and we were able to see that there is no family history of cerebral ataxia, but a family history of autoimmune diseases, associated autoimmune diseases, such as diabetes mellitus, thyroiditis, vitiligo, Birmer's disease, in around half of the family of these patients. And the patients developed in 70% of cases late onset diabetes mellitus or other autoimmune diseases, thyroiditis, pernicious amnesia, psoriasis, celiac disease, and sometimes cancer, but very rarely, such as malignant thymoma. And most of the patients are other organ-specific autoantibodies, suggesting a particular field to develop autoimmune diseases. And the CSF was inflammatory, suggesting that it was an immune-mediated cerebral ataxia, but without associated cancer. And so we have many arguments suggesting that paraneoplastic cerebral ataxia was only the top of an iceberg, with a lot of patients with autoimmune neurological syndromes, but without associated cancer. And so we can suspect other type of immune mechanisms that could explain the neurological symptoms. And it was clear in 2007 with a work of Joseph Dalmau from UPenn, who described patients with autoimmune encephalitis. The first patient was paraneoplastic with the presence of ovarian teratoma, but very quickly, most of the patients have no cancer. You can see this woman, it was 18 years old, and she developed an NMDA receptor encephalitis. She developed psychiatric symptoms with hallucination, and after that, dysautonomia and abnormal movement with orofacial dyskinesia. And she totally improved. It's the same woman after immunomodulation. She received immunoglobulins, cyclophosphamide, and rituximab. And you can see her 2 years after that, and she totally improved. So it was highly surprising and suggesting that it was not a neuronal death, but a neuronal blockage. And so after that, Joseph Dalmau and others described a lot of different autoantibodies associated with particular clinical signs, sometimes limbic encephalitis, but also ataxia in some patients. Some of them were paraneoplastic or never paraneoplastic, such as glycine receptors or Caspr2 and LG1. And so it was the description of many different kinds of autoimmune diseases associated with different kinds of autoantibodies. And so we were able to describe the evolution and the ability to treat or not this patient. And so we changed our concept. At the onset, it was cerebral ataxia, paraneoplastic, with the description of cancer, like in HU or YO autoantibodies. But in fact, these autoantibodies are good biomarkers of cancer and immune reaction, but do not play a direct role, and it's associated with a neuronal death. So we have to identify very quickly the tumor to stop the immune reaction, but we are not able to improve the patient with immunomodulation. And in another side, we now describe patients with membrane antigens, and you can see that DNAR is in this group. It's not associated with cancer, but we developed different studies demonstrating that these autoantibodies play a direct role in the disease and are able to block the functioning of neurons. And so if you remove the autoantibodies, you can improve the patient because there is no or limited neuronal death. And sometimes it's more complicated. The target is intracellular, but we may have improvement of the patient with immune treatments. And we also identified that these diseases are highly underdiagnosed because not all the labs are able to identify all the autoantibodies. And we show that in France, we are probably able to diagnose only half of the patient with such disease because not all the biological labs are able to identify the autoantibodies. And we described a lot of change of semiology and clinical presentation. You can see this patient of 61 years old patient. He developed focal temporal epilepsy with weak memory disturbance. And after a generalized seizure, he was hospitalized, and we identified a high level of anti-caspr2 autoantibodies in the serum and CSF. And you can see what's happened with acutely some paroxystic cerebellar ataxia. You will be able to hear the dysarthria.
Je l'ai entendu hier soir à la radio.
Even if it speaks French.
Le vase est dans la salle à manger.
Le vase est dans la salle à manger.
Mets-toi debout, pieds joints.
So you can hear the dysarthria. You can see that there is a mild cerebellar ataxia.
Le vase est dans la
And
salle à manger.
only few seconds later,
Le vase est dans la salle à manger.
Le vase est dans la salle à manger.
Je l'ai entendu hier soir à la radio.
Je l'ai entendu hier soir à la radio.
the dysarthria disappeared completely. And also all the cerebellar sides. And so in fact, these patients had antibodies against caspr2, and we know that caspr2 is able to clusterize in the synapse the potassium channels. And we know that mutation in the potassium channels in some patients with genetic disease provoke exactly the same paroxystic cerebellar ataxia. And everything disappeared with treatment, immunomodulator treatment, such as cyclophosphamide and rituximab. And the patient is now totally normal. And so we can suspect that the autoantibodies played a direct role to change the clusterization of potassium channel, and we checked that there is no mutation in these patients, and it was only an immune cerebellar ataxia. And so we look at in all our patients with anti-caspr2 antibodies, and we observed that this ataxia, paroxystic ataxia, was present in 30% of cases. And so we were able to describe a new disease that was unknown before the identification of the autoantibodies. So I cannot present all the autoantibodies, just to say that in the last years, we described a lot of different autoantibodies associated with particular kind of cerebellar ataxia and particular evolution. So you can see GLUR2, ETPR1, OMF3, septin5, TRIN9, 7, TRIM46, RGAP26, CARP8. So a list of autoantibodies, but you can see the number of patients that have been described is very low. 20 patients for GLUR2, 7 patients with ITPR1. We are working on a series of 13 patients with TRIM9 autoantibodies, so it's very, very rare, and it's not only patients in France, but patients around the world. But it demonstrates that you may have some unknown disease associated with particular autoantibodies that can explain some particular cerebellar ataxia. And it's very important to identify this patient because you can see this patient from Toulouse with a very, very severe cerebellar ataxia with opsomyoclonus. He was unable to walk, and we treated him by immunomodulators, and it's the same patient. You can see that he completely improved after treatment, demonstrating that it's very important to diagnose correctly this patient to be able to treat them correctly and to be cured. So what are the mechanisms? As you saw, you may have different mechanisms. It could be the tumor. Infection could be possible because we described NMDA receptor encephalitis post-herpes infection. And we can also suspect some particular genetic. And so we studied these different hypotheses. First, we studied the tumor of the patient and ovarian cancer of patients with paraneoplastic cerebellar ataxia. And we identified that, in fact, the antigens, YU antigens, is highly expressed only in ovarian cancer of patients with cerebellar ataxia, paraneoplastic cerebellar ataxia, and not in the tumor of patients without paraneoplastic cerebellar ataxia. And so it's very important because the pathology of the ovarian or breast cancer of this patient is not specific. It's usual, like all the ovarian carcinoma or the breast carcinoma. But if you look at the molecular level, in fact, it's totally different. We observed amplification of the chromosome 17 in patients with ovarian cancer and paraneoplastic cerebellar ataxia, and also some specific abnormalities and mutations in patients with paraneoplastic cerebellar ataxia. And so the molecular characteristics of the tumor of patients with paraneoplastic cerebellar ataxia is in fact totally different than the tumor of control patients without paraneoplastic syndromes. And so it's very important to conclude that the tumor is the trigger of the immune breakdown and the immune reaction against the cerebellum. And we also look at if there is some genetic link, and we demonstrated at least 3 mechanisms. So paraneoplastic, there is no particular HLA haplotype associated and no particular genetic clues. Everything is in the tumor, but on the opposite, patients with Casper2 or different other autoantibodies are associated with a particular genetic link called HLA, and the immune reaction is different because it's IgG4 that are associated and not IgG1. And in this case, it's a neuronal blockage and not a neuronal death. And so in paraneoplastic, you cannot improve the neurological symptoms of the patients. But in patients with IgG4, you can totally improve the patient and cure them with immunomodulators. And it's a genetic treat that suggest that all people are not able to develop such neurological disease, but must have some particular gene to be able to develop the disease. And we also have some other patients who are not IgG4, but IgG1, and also T-cell mediated disease, and are associated with particular HLA haplotype associated with autoimmune diseases. And so in this case, the mechanism is also different. And so we identified at least 4 different immune mechanisms that can explain cerebellar immune-mediated ataxia. Sometimes it's paraneoplastic, and the tumor is responsible of everything. Sometimes it's a mix of neuronal blockage and neuronal death, and it's a link. In some patients, there is a link with other autoimmune disease, and sometimes it's a particular immune reaction, IgG4 mediated, in close relationship with a particular genetic expression of HLA class II. So we cannot put together all the patients with cerebellar ataxia, but there is different mechanisms with different kind of treatment and different kind of evolution. And so this one is to explain, this slide is to explain that cancer is only one trigger, but the immune system can be activated by different way, and sometimes only the humoral immune system, and so autoantibodies can block something in the neurons, and sometimes it's an activation of the immune cells, and so destruction of the neurons. And so in some patients, both cellular and humoral immunity may be involved. And so what will be the future of autoimmune cerebellar ataxia? It's an open field, and we can describe a lot of different disease, and we have to work on many different aspects to be able to understand very precisely the mechanisms of this disease, and what does it mean to have an autoantibody associated. Sometimes it can be used as a diagnostic biomarkers, and sometimes it is also involved in the mechanism of the immune reaction. And it's very important to understand very clearly what are the different mechanisms that are involved in immune-mediated cerebellar ataxia. Because if we understand very specifically these different mechanisms, we will be able to propose some specific treatment to the patients, sometimes to remove the autoantibodies and to improve the patients, and sometimes to be able to propose something to improve the neuronal reparation and to improve the neuronal functioning of the patients. So we have a lot of work, first to describe correctly all the cerebellar ataxia immune-mediated, to understand the mechanisms of each patient, and to propose and study different treatment in these patients. And more importantly, we have to develop animal models to be able to decipher the mechanisms of these diseases. Just to conclude, a presentation of another cerebellar ataxia, you can see this woman with chorea and ataxia. She had IGLON5 autoantibodies. These IGLON5 autoantibodies have been described at Francesc Gros in Barcelona in 2014. In some patients, with involvement of the brainstem and sleep breathing disorders. And the particularity is that these patients have autoantibodies, circulating autoantibodies in the CSF and serum, but without inflammation in the CSF. There is a particular HLA association suggesting an immune disease, but they can have sudden death. And so we have some autopsy of these patients without inflammation, but deposit of tau protein in the neuron, exactly like a neurodegenerative disease. And the symptoms are very slow to develop. And so the patient present like a neurodegenerative disease and not an immune process. And so it's a mix of immune origin and degenerative disease. And it's very important because it's a link to understand exactly what's happened in the brain of some patients. You may have a trigger, an immune trigger, and after that, a processing of neurodegeneration. And so it will be very important in the future to understand this disease and to be able to understand the mechanisms and to look at if in some more frequent neurodegenerative disease, the immune system could not play a particular role, and so to treat or to improve some patients with presentation of neurodegenerative disease. So to conclude, immune cerebellar ataxia are very rare. The syndrome are being described and the incidence is unknown, and so may have a clinical presentation look like neurodegenerative disease. The classification and clinical symptoms depends on the associated autoantibodies. There are clinical specificities according to the associated autoantibodies, and CSF and brain MRI can be normal, and so it's not always obvious to conclude of the role of the immune system, and sometimes difficult. And autoantibodies should be investigated or verified in an expert center because it's not so easy to be sure of the positivity and negativity of autoantibodies in some patients. And so the physiological mechanisms could be different according, or may be different according the different kind of patient. And it's very important to look at the genetics that could play an important role in some patient. And the search for an associated cancer depends on the type of autoantibodies, the age and the sex of the patients, and treatment are not yet codified, but some patients can be cured by the immunomodulatory treatments. And so you may have some information in our website called BEPSI, because it's our last funded grant, and you will find all our articles. And it's my team and our collaboration on this work. So thank you very much, and I hope that I was no too technical to present these particular diseases.
Thank you for a fantastic talk. We're going to shift into our Q&A session now. Just a reminder for folks who are attending, if you do have questions, please drop them in the Q&A window at the bottom of your screen. And a reminder, if you are raising your hand because of how the webinar is set up, we can't unmute you. So if you could please instead put your question in the Q&A window, I'd be happy to read it out. So let's start with our first question from a listener. So this is about the different kinds of immune responses that can cause immune-mediated cerebellar ataxia. Can a Lyme disease infection trigger immune-mediated ataxia? If so, what would be the diagnostic tests that someone should run?
And so we don't know exactly for Lyme disease, but generally, yes, we think that infection can trigger autoimmune cerebellar ataxia. And we think that it's a post-infectious disease, but we don't know exactly what's the role of the infection and which kind of infection are able to trigger this kind of disease. And so we are working on these different aspects, and I hope that we will be able to answer, but in few years.
More research is needed, but that's good to know. The next question is from an attendee who has had ataxia symptoms for about 9 years. All genetic tests are negative, all scans for cancer are negative, but recently she had a positive test to an ANA screen, which for folks who aren't familiar with that is a screen that can detect a bunch of different autoantibodies. And they're wondering that this is a very recent development. What should they do next now that or what should their clinician be doing next now that they know that they're having some kind of immune response in addition to having ataxia symptoms?
Yeah, it's a very complicated problem. Because I presented some clues that you may have a link between neurodegenerative and immune reaction, but need to have clear biomarkers. If there is no clear biomarkers, it's always difficult, and you have to discuss with your physician what could be the best, but be careful because we use some molecules that can provoke immunodepression. And so sometimes it's better to have some neurological symptoms, but no infection and no hospitalization because of very severe infection because of the immunosuppression. And so it's a balance and the discussion with the physician. And so I don't like to treat patients without clear biomarker. Sometimes we try, but you have to ponderate
very difficult.
the best treatment, and must be discussed with specialized of these diseases.
We're also getting a few questions from folks who are in the US and wondering who should they go to for medical questions because you're located in France. I just want to direct folks to our previous speaker in this series, Dr. Natalie Wittick from Rush Medical Center in Chicago, who spoke with us 2 weeks ago. She's a fantastic resource. So that webinar is on our website. If you want to take a look at that for some more US-based resources, that's where I direct you. Our next question is around CSF findings. So what are typical CSF findings with autoimmune ataxia? What is the significance of high CSF proteins without elevation of cells, IgG, or oligoclonal bands? So is there a connection between that and autoimmune ataxia?
It's another very important point. When we describe the first cases of paraneoplastic origin, most of the patients are CSF highly inflammatory with cells, oligoclonal bands, cytokines elevated in the CSF. And so the answer is it depends the associated autoantibodies. If it's a paraneoplastic case, such as YO or HU, the CSF is inflammatory. But in some other cases, you may have a normal CSF. And so the CSF is now one argument to say if it's immune-mediated or not. But IGLON5, the last that I presented to you, the CSF is normal. There is no inflammation, but the trigger is immune. And so it's not now the best way to know if it's immune-mediated or not. It depends of the different biomarkers, it depends the story and how to diagnose that it's immune-mediated, but sometimes the CSF can be normal.
It just goes to show how complex it is and how it's helpful to contact a specialist who has some experience navigating all the ins and outs of this group of diseases.
Exactly.
So our next question here is about autoantibodies. Do you suggest getting retested for autoantibodies every year or so if you haven't found a clear cause yet?
Sorry, what?
Yeah, no
What the
worries.
question?
Do you recommend getting retested for different autoantibodies every year if you haven't found a clear cause of ataxia yet?
In fact, it's not the retesting the most important, is the location of the testing. And so the lab will receive the CSF and the serum and you will perform the test. Because there is some commercial kits to identify the autoantibodies, and sometimes the sensitivity and the specificity are not right. And you may have a positivity in one lab who are not specialized to identify the autoantibodies, and it could be a false positivity. And so it's very important to discuss with the reference lab. So you have some of them in US that are able to have a right diagnosis. But before to conclude that it's positive or negative, if in the first test, in the right lab, it's negative or positive, it's true. It's not the right lab. It's not necessary to have the second test. You must find the right lab to test and to have a clear answer.
That's very helpful to know. And then we're going to try to sneak in a couple last questions before we end off today. We have a question from an attendee. What antibodies should be tested for gluten ataxia? Could you tell us a little bit about that?
Yeah, and so it's a difficult problem because it's antityrosine 6 that have been described, but there is a location in England in near Sheffield with the description of gluten ataxia, and it's not reproduced around the world, and so it's a difficult question. And we did not exchange samples enough to know if we speak exactly to the same disease. So it's clear that patients with well-described gluten sensitivity and some with a right diagnosis about gluten, you can develop cerebellar ataxia. But it was also described in patients without bowel problems and without clear gluten sensitivity. And so I don't know. I cannot answer clearly, but in France, around Lyon, I never seen such patients. So I don't know if it's specific of some country or some aspects.
So more work needs to be done in that area too.
Yeah.
But that's really good to know. And then one final question. Are there any specific diets that can help folks who are having autoimmune ataxias, in addition to the specific case of gluten ataxia with a gluten-free diet?
I don't know. I can answer. No, I think diet could play a role. I think that when you have a cerebellar ataxia, the most important is to have good muscle and to be in a good form. And so to have a sport.
So regular exercise, a healthy diet.
A normal life with normal alimentation, with various things, not to be carential. It's very important. And the muscle is very, very important about the ataxia. So it's my only advice for the diet.
Mhm. Well, thank you so much. And thank you for everyone who stayed. I know we're a little bit over time, but if everyone could join me at their individual computer screens, thanking Professor Honnorat for joining us today and sharing with us some of the cutting edge research that's being done on immune-mediated ataxia. So thank you so much for joining us today. And thanks to all of you for listening. I hope you found something valuable here. So wherever you are in the world, good morning, good afternoon, good evening, and we hope to see you at another session another time. Hope you have a wonderful rest of your day. Bye, everyone.
Okay, thank you very much. Bye.